Zoll has pushed the boundaries of what is possible for 35 years, in the tradition of company co-founder Paul Zoll, a Lasker Award-winning physician and a pioneer in pacing and defibrillation. In addition to his seminal research, Dr. Zoll had a reputation for dedication and careful attention to his patients. His legacy lives on at Zoll.
Thank you, Associate Professor Chung and Professor Wang. Ladies and gentlemen, it's a pleasure to be here. And I wonder if you ever imagined that the resuscitation organizations would ever not recommend ABC, give 100% oxygen, give epinephrine, or stop CPR after 20 minutes. I have no relevant conflicts, although I have some research grants and sit on some voluntary scientific advisory boards. But nothing that I'll say or show you today is intended to endorse any specific product or drug. And I'll remind you that all of the information about the topic I'm going to talk about and all the topics here is available to you free through ilcor.org online for each of the questions and topics that we cover. By way of disclosure, we're talking about advanced life support, but I believe that the most important part of advanced life support is actually good, basic life support. And I also acknowledge that perhaps we have to think about the tools, the simple tools that we have that we can put in place that make the most difference before we think about the fancy gadgets that comprise advanced life support. If you think with me, there are phases of resuscitation, including the pre-arrest phase, where we can use advanced techniques to define how to protect, to identify and predict cardiac arrest. During cardiac arrest, very simple interventions that promote blood flow to the heart and brain. And then during the low flow state of CPR, you just heard the few things that we can do that are both the same and slightly different from adults. However, the very important post-return of spontaneous circulation, where we resuscitate and regenerate, has some targets where advanced life support offers great promise. If you think about advanced life support, in my hospital, at the Children's Hospital of Philadelphia, we have 540 pediatric beds. 40% of the hospital beds are intensive care. If you look at the large number of providers that we have in my ICU, and you do the calculations, there are more than 1 million combinations of 5-person teams that would respond to any given child who arrests in my hospital. So when we think about advanced life support, we have many providers, we have many tools, we have many opportunities, but delivering that with high quality is perhaps very difficult. And so our teamwork becomes extremely important in advanced life support. In fact, in pediatrics, in-hospital CPR is an ICU problem. Across the country, from our National Registry of CPR, more than 95% of cardiac arrests for children in hospital occur in an ICU setting. We have invasive monitoring in more than 60% of those patients' arterial lines. And so physiology-directed CPR is perhaps very possible in the in-hospital setting. And we know that the patient response is quite variable. So when we switch from basic life support in those first few seconds and minutes of resuscitation to the complex arena in which pediatric cardiac arrest occurs and the major tools that we have at the bedside, you can see that we have a lot of technology and a lot of potential to use advanced treatments. But where is the human in this picture? Where is the team? Well, if we think back about the tools from 1961 in the original publication by Jude and Knickerbocker and Cohenhoven in JAMA in 1961, if you look at that article, they had blood pressure tracings from those 20 patients that had cardiac arrest, and look how good the diastolic blood pressures are that they're achieving. They had part of the answer there. So when we have advanced technology, advanced information, we can titrate our therapies to a goal. And we know that higher coronary perfusion pressures, higher diastolic blood pressures, are associated with better outcomes. So we have guidelines, we have medical standards, we teach these, and we try to learn and remember them. But in our chain of survival, at each step that we go from one chain to the next, we lose some translation. We're lost in translation. And so in many hospitals, our survival is 22%. But when we apply advanced techniques to achieve the guidelines, we use rapid cycle, deliberate practice, and achieve the guidelines, we can improve survival outcomes and almost double in intact neurologic survival from 22 to 54% in selected settings that have done this with basic and advanced life support and rigorous practice. We know that the patient has factors, the event has factors, the system has different challenges, and that when we do an intervention, whether it's education, technique, device, drugs, or system changes, the quality with which we do them impact the outcomes that we care about: return of circulation, short and long-term survival, more importantly, intact neurologic survival and quality of life. But when we think about advanced life support, and perhaps an intervention like what Bob Newmar was talking about earlier, cooling is not a single intervention, because cooling and rewarming affect the duration of action of our sedatives, the blood pressure titration, the vascular resistance, the ventilation, the glucose control, and protocol adherence, and excellent attention to these post-resuscitative factors have intense impact on the outcomes that we achieve. So it's not just putting a cooling blanket under and on top of a patient, it's the whole complex advanced life support therapies as a bundle that we're applying that make all the difference. We are getting more technologically sophisticated to be able to recognize and alert and respond to patients before cardiac arrests occur. As Richard Aiken said, we have not identified a single medication, no single medication, that has proven to be associated with long-term survival. So that although we still recommend epinephrine, and we are now learning from our registry data the association of early epinephrine in the in-hospital setting and the timing of that epinephrine with outcome, we don't have proof that in randomized controlled trials that it's actually needed. And so we'll learn more about that in the near future, but that we should perhaps rely a little less on our drugs and the exact dosing of those drugs and pay more attention to the basics. Once we have return of spontaneous circulation, we should perhaps think about the key elements in advanced life support that are associated with improved outcome. We heard before from Jerry Nolan about targeted temperature management, a protocol of cooling to a targeted temperature, Bob Newmar as well, cerebral perfusion, blood pressure management, avoiding even a single drop of blood pressure post-arrest, oxygen titration, control of seizures, and control of glucose. We're learning more and more that we have to get it just right. Too much or too little oxygen is associated with worse neurologic outcomes. We know from animal studies and now emerging studies on cardiac function post-return of spontaneous circulation that there's a period of myocardial dysfunction with or without coronary abnormalities that occurs reliably when there's a prolonged cardiac arrest. And so better management and close attention to the details of how to avoid post-return of spontaneous circulation hypotension become increasingly important. targeted temperature management, whether we select 32 to 34 degrees or 36 degrees, becomes important, but as we heard, we aren't quite sure about how to apply it. Recent studies, including the Pediatric Therapeutic Hypothermia after Pediatric Cardiac Arrest trials, the out-of-hospital cardiac arrest trial completed, and now the data just being completed on the in-hospital trial with a 48-hour period of therapeutic cooling to 32 to 34 degrees, and then 3 additional days of therapeutic normothermia compared to a 5-day course of therapeutic normothermia, has not yet proven to be of advantage, no significant improvement, although the absolute difference in survival and neurologic outcomes is better, but not statistically significant for the intention to treat trial. So there are many remaining questions about hypothermia after cardiac arrest. We have questions about who to cool, how to select those patients, when to cool, how to cool them, and indeed how long to cool and how deep to cool, and then how to rewarm them, how fast to rewarm them, and how to prognosticate in the absence of data of how to do that and how to do that accurately in the face of hypothermia. What is emerging is the sense that there are likely some patients who have such severe injury, children who will not respond to any therapy, including targeted temperature management, and there will be those that have such minor injury that they'll have good outcome regardless of whether they're cooled or not. But there are likely those that could be identified that might have more advantage from a dose of targeted temperature management that could be titrated to the degree of injury. We've heard that identifying seizures and EEG patterns is becoming increasingly important and will likely emerge as an advanced life support tool to guide our therapies and to measure perhaps our therapeutic effect. Improved elements of quantitative EEG assessment that are easy to interpret at the bedside, such as density spectral array EEG or amplitude integrated EEG, may assist the bedside provider in identifying EEG patterns as opposed to having to wait for a neurologist or neurology expert to have to interpret complex standard EEG patterns. We're learning to be a little less reliant on duration of CPR as a marker of survival and neurologic outcome. Although we know that there's an association of longer periods of CPR with worse outcome, because the quality of CPR is so important, it is less a duration of CPR, but perhaps a duration of good quality CPR that we should be relying on to base whether we continue or apply more advanced techniques. On the horizon for adults and children, as we're hearing, is the potential for emergency preservation and resuscitation, or eCPR. Although what's pictured here is a very large model of CPR pumps and monitors with a very small patient, that technology is becoming smaller and smaller and more portable and easier to implement. And so our titration of oxygen, our titration of carbon dioxide, our control of temperature, and our control of blood pressures could become easier and easier. And our therapeutic modulation of that post-arrest period and reperfusion is on the horizon to be quite well controlled with ultra-advanced life support therapies. As we heard Cliff Calloway talk about, the prognostication is not easy, but there is some emerging evidence that we can use tools that will help us in both the normothermic and hypothermic patient to start to figure out in certain time periods where prognosis can be applied and where we just have to wait. We're quite anxious in the advanced life support world to find adjuncts that will improve both the quality of CPR and blood flow to heart and brain. But these are not likely to be machine alone. We can't think simplistically that a simple machine is going to solve our problems. It's not man versus machine, it's man and machine, time after time after time. And Gavin's going to talk to us a little about that in just a few minutes. When I think about the transition of basic to advanced life support and how we could apply that to improve outcomes, I would be remiss if advanced life support didn't also include how we train and implement our system of care that integrates basic and life support in a manner using real-time feedback, using just-in-time training, and using performance debriefing to both critique and improve future resuscitations. We're at a point where we're just reaching the tip of the iceberg of what we can do and what we can aspire to do. Our cardiac arrest teams and our systems of care have to improve. We have bundles of care and bundles of treatments that can and do work when they're implemented for selected patients in selected patients with high quality in practice. But that's not the rule, that's the exception these days. And so we have to think about how we can identify patients pre-arrest using sophisticated tools and sophisticated, short, repeated, high-frequency training. How during arrest we can use our current tools to feed back the quality of CPR and use very frequent proactive training or dress rehearsals to improve the quality of our post-resuscitative care in order to improve and measure outcomes. Perhaps in the future, with telemedicine, teletraining, and telesurveillance, we'll be able to have more centralized support for those that don't have the resources to do all of this on their own. Perhaps we'll be more like our professional sports teams, using instant replay to inform our practice, to review what happened, and to try to identify and do better instantly with high stakes. For the future, I think we're looking at an advanced life support scheme that includes improved surveillance, early detection and rapid response, practice team performance with monitors and coaches, the integration of man and machine with mechanical CPR and ECMO, and a post-resuscitative care that takes the whole bundle of advanced life support and integrates it and performs it with high quality. As we move towards 2020, we will discover by measuring, we will process it better to teach, learn, remember, act, and act well. And with that, we will achieve great things. We will figure out what can work, what does work, and if it works, we should see improved neurologic survival and quality of life. It's not going to be easy. This is the team that I get to work with when I work every day. It's a great team, and we need to form more of them. Thank you very much.